Hello and welcome to today's webinar, FHIR-Side Chat, Information for Health Insurance Providers. Today, our speakers will share their expertise and real-life experience developing FHIR-based solutions for health insurance providers. Our speakers are Duncan Weatherston, Hayes Abrams, and the discussion will be moderated by Aneesh Chopra. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available a few days after the session. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. As this is a FHIR-Side chat, you, the viewers, decide on the direction of the discussion by the questions you ask. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the handout section at the bottom of your screen. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. Now, I pass it on to Aneesh to start the discussion.
Well, thank you so very much. It's going to be hopefully a productive and informative conversation. As mentioned, my name is Aneesh Chopra. I'm the president of CareJourney and pretty excited about having my friends Duncan Weatherston and Hayes Abrams to join. Just a quick introduction on both. Duncan is the CEO of Smile CDR. Over the past 20 years, he's been a key architect in the creation and delivery of regional health information technology architecture and strategy in Ontario, Canada. His work has addressed the design and delivery of coordinated health record integration across more than 200 hospitals, nearly 250,000 healthcare providers, and serving a patient population north of 14 million people. So, hey, Duncan, a quick hello to you.
Hello. Nice to meet everybody.
And then we have my buddy Hayes Abrams, who currently serves as the Executive Director of Network Strategy and Implementation at BlueCross BlueShield of Illinois. In this particular role, Hayes is responsible for identifying and establishing health data exchange opportunities with the provider community and for enhancing the quality of care for Blue Cross Illinois' 8 million members. Welcome to you, my friend Hayes.
Hello, thank you. Thank you both, and thanks to our AHIP friends for having us here. I'm an AHIP fellow, so big call out to that. So glad to be here, Aneesh. Glad to talk to you too, Duncan.
Great. Why don't we dive in? I think as we heard at the outset, we're going to take questions from the field, but in the interim, as moderator prerogative, I suggest we may start the conversation with a few baseline questions, both to Duncan and Hayes. My perspective is we may think of this conversation in three chunks: a bit about the current stage, where we are today on this discussion, with respect to readiness, for lack of a better term, on interoperability. We then might want to get a little bit closer to the scope of work that you're prioritizing, given the regulatory requirements and business opportunities within the enterprise. And then if we're lucky with time, we may lift up a bit and forecast a bit on the future. So with that in mind, I might suggest, Hayes, I turn a bit to you. If you wouldn't mind allowing the audience a bit of a window into your life, the role you play involving data sharing and provider engagement probably has a litany of ways in which you operate today. Could you just give us a bit of the baseline? What is the nature of interoperability from your vantage point?
Wow. Well, thank you. I probably go back. I've been doing this for 28 years now, and I kind of go back to maybe some of the more traditional definitions. Kind of started with in the late 90s, early 2000s, around interoperability. It was really more akin to how the banking industry works. I've seen a lot of different definitions today, and everybody's really chasing what CMS and ONC have put down there. It's a patient-facing API. I think that's a phenomenal start for the math. I think what we really look at is how do we get into that next level or two down, and how do we really get closer to workflow. You're not going to be able to truly help our community until you really get that convergence of patient, provider, and really get into the workflow side of things. So I really go back more to that sort of health meets wealth be like the financial industry sort of model for interoperability. Patient-facing APIs are fine and well, and it's going to get us on a great journey going forward. How CMS has defined the provider directory, okay, that's nice. That's not going to quite move the needles that we're held to. So I'm a little closer to deeper data integration, deeper information providing to the providers in their workflow is really what we're targeting.
Yeah, and Hayes, as I dial, let's peel the onion back just a few words here and there, and then we'll get Duncan to chime in. There is, I hope through this discussion, a link between the investments made to enable consumer access to this information and how it may be repurposed and reused to address some of the direct clinical workflows that you just alluded to. We'll get there later, I think, in the call, but just to sort of baseline on setting the stage, from your vantage point, assuming you have, and maybe that's an assumption we should test, the contractual ability to share information either from a provider in a network or to a provider within a network, might you just share a little bit about the how in the world of today, and let's call it pre-FHIR, under the assumption that very few of those connections today are on FHIR. Just give us a bit of the life of assuming you've got contractual rights.
Yeah, so our guiding principles in the connectivity space definitely start with a line to the network contract. I actually am in the Illinois network provider network division. So definitely, it's not follow the money, right? So alignment to the network contracts, putting information where the clinician already does business, wherever possible, be multi-payer. Use standards as a guidepost, not an absolute, and avoid point solutions. Those are our guiding principles. And so we really, have stayed true to that. And, I think this is where it's nicely going with FHIR and R4 within the CMS ONC regs for 2022. But we definitely think that's a powerful mechanism to help us because I think it shows a shared commitment. It starts with that level of trust. Hopefully I hit that for you, Aneesh.
That may be a great segue into if I can bring Duncan in. I want to just, before I do that, confirm what you said. Avoid point solutions. That was an easy phrase to utter. Can you just level set with the audience? Is that reality for you today, or are you finding yourself with custom integrations, point-to-point interfaces?
Yeah. So I said our guidance principles, it wasn't always how we we behave, right? But if we're truly going to try to get to that deeper integration, interoperable, closer to the provider and patient, again, no, not member, but patient, and where they do business, if I have too many one-off processes that aren't aligned to the provider's workflow with a multi-payer mindset, we're never going to achieve those means. But no, we definitely are constantly fighting at the line of scrimmage. Also try to, kind of trying to go out, a little bit wider out with, like we're probably going to talk about with FHIR. But it is not, point solutions are definitely in my reality, unfortunately.
And so Duncan, we bring you into this conversation, in part because of the expertise is brought to bear on the FHIR standard. And I'm wondering, from a place of standardization to a world that has rife with point solutions, can you chime in a bit about the landscape, the current state, as we move to a more standardized future?
Yeah, absolutely. I think so. The critical path that we're on right now is a sort of trajectory from point solutions to what is driven by an open standard, is what I call like the Internet of Health, where there's this opportunity for participants to leverage the fact that everything is open to be able to create capabilities that feed into what would previously have been point solutions, allowing the creation of capabilities which are unique, but in a way that can be leveraged over and over again, and not become isolated or become sort of stratified, right? So if you think about where we were right now, for example, you have some data in an isolated system, and if you want to be able to gain access to it, you have to create some mechanism to interact with the information at its points where it sits in the environment. in the future, you create an exposed capability that has still at its heart some information, but because you're adhering to something like FHIR, an open standard, you have the ability to interact with it at the destination point. You don't ask for the information to be sent to you and figure out what you want to do. You interact with the API, get the information you want out of the environment in the way that you want it, and then just use it immediately. And I think so there's definitely a trajectory from here to there in terms of leveraging the information, the existing solutions, and making them more sort of globally useful.
Well, you're introducing us to the how a technical standard might enable that leveraging, and Cytran posted a question that I think is really at the heart of where people's minds may be right now, which is the CMS Interoperability Rule and how the conversation we're having around FHIR, the current state, where we're heading, might relate. Maybe we'll use this as a way to dive into that conversation right now. And if you'll indulge me, moderator, freedoms here to sort of reemphasize and summarize principles of the rule. First and foremost, CMS has asked all government-sponsored plans to furnish a patient access API inclusive of claims history and clinical history that may otherwise have been collected on the course of business by July of this calendar year to an application of a consumer's choice. In addition, there are broader bulk files with respect to a physician directory, which may not involve a patient's individual clinical or health records, but is accessible to their plan or network. Similarly, a formulary for medications. And on the physician side, CMS requires hospitals to furnish admissions, discharge, and transfer feeds that would be on a roster of patients physicians submit with respect to the my patient showed up in the ER, please alert me functionality. These rules, the CMS Interoperability Rules, are essentially hand in hand with a set of interoperability rules established by the Office of the National Coordinator, largely on the issue of electronic health records and the obligations they share to make information available to consumer apps, but more broadly to regulate the concept of information blocking, rules and conditions under which information as requested and contractually accessible can be administered, perhaps in a manner that Duncan described as leveraging infrastructure, i.e. standards-based. So I think the size question about elaborating on the CMS rule and how it relates to, we'll squint a bit, Hayes, to get back to where you are on the provider network enablement, but could you maybe try to crosswalk that a little bit for Cy? What is happening at BlueCross generally, HCSC on this, on the rule, and then how do you see that work affect?
Okay, great. Okay, thank you. Sorry, so the question is, what are we doing near term to address what the regulations for this year? Is that in essence the question for my friend at BlueCross? Okay. Well, at HCSC, which is really the 5-state Blue that I work for, we're trying to be strategically compliant. So we are definitely harnessing our data in-house, establishing the patient-facing API, actually working with Duncan's team, and bringing that claim data, the lab results, the clinical data, meeting US CDI specs, to a patient-facing API to serve up to the marketplace. And we're also working towards our the provider directory feed that we have to do, and then the payer-to-payer exchange that's coming as well. But I say strategically compliant because we're also looking at ways to expand our, I use sort of an arrow and quiver analogy, but with our FHIR services, how can we get to that, Internet of Health that Duncan mentions? And so while we're driving, down that mandate compliance road, we're also saying, well, how can I start leapfrogging and start taking advantage of the services that we get with our FHIR environment and the energy that's going on outside about doing FHIR, and start building our ability to have another arrow in which we can go and connect to the providers in the marketplace and do the things that I kind of noted in my guiding principles and my aspirations. So we are definitely being very compliant, but also picking up opportunities and working with folks like Duncan and Aneesh on where we can actually start differentiating in the marketplace because of the capabilities.
Duncan, let me turn to you. Can you connect the dots? I think Hayes gave us a beautiful linkage here between strategic compliance as a model. Can you just start with, walk me through a day in the life of your phone? I think it's ringing off the hook because payers have to meet this requirement pretty quickly. What is what we would call traditional compliance, and how to bridge to strategic compliance as Hayes just referenced? Duncan, would you mind just kind of day in the life a little
absolutely.
bit on compliance?
So actually, I think it's a really important point. The current demand is that you be able to share information with your members, ostensibly using a Smart on FHIR application, and that there's a constrained set of data that is limited to what you have in hand, essentially, that you have to share. And we've had lots of conversations with people about how to interpret that. Does this piece of information that's sitting over here in this external system count? So the traditional discussion we've had is how do I meet the compliance rule to the extent that information I have in my environment is available to a third-party application using a FHIR API. It kind of aligns with the traditional way of thinking about data transfer. I have some information sitting over here, I have a device over there I have to get it onto, I send the data over. If you think about it from a strategic perspective, though, you've got an opportunity to take the data that you have in your environment from patients and from providers and convert it into structured information that can then be used in ways that are forward-looking. You can have, for example, that information feed into interactions with clinicians at the point of service or point of care. You can have that information be aggregated in ways that could be used by sort of modern analytics and AI to be able to do predictive assessment on future transactions. If you think about the whole solution in a strategic perspective, what you should be considering is that you're exposing your information assets to technologies and capabilities that will enable you to leverage the quality and structure of the information to achieve outcomes which extend far beyond the base mandate. And that, I think Hayes is exemplary of that in his vision for interacting at the point of care and providing real clinical value from the information that BlueCross BlueShield contains.
Duncan, I'm going to ask you to stick on this section and just take another stab at this to help me, walk through this for the audience. And so, in the traditional model of interfaces, we'll go back to Hayes' language of point solutions or avoiding point solutions. In interfaces, one would set up a connection where that source data is exposed, and then you can turn on the connection, maintain the connection, and then you got to do it again for the next and the next and the next. In this scenario, when we move towards leveraging and this idea of FHIR infrastructure, it introduces the concept of applications and theoretically reusable applications. Duncan, would you be so kind as to just explain what would a Smart on FHIR application be, and how might you think of it in a different way from an interface? And we'll come back to that concept of leveraging the investments for compliance to provide that in the hands of a clinician.
Yeah, so the Smart on FHIR is the mechanism by which we can enable applications to interact with the information in ways that are new and meaningful. And I think this is a really other critical point, right? So you're right, Aneesh, I should have elaborated a bit further on that. When you're building an application today that just gets information and renders it for you, here's a list of things I got from that source, and now you scroll through a list and see what you got. The value that you receive from that is relatively low. The creation of applications that take advantage of FHIR's capabilities enable you to do really interesting collaborative things. So for example, the standardization of the data interfaces and the functions for requesting information enables you to build applications that can do more complicated information tasks with the information residing in, for example, the payer's environment, and then coupled with information which resides in the provider environment, present a whole wealth of new tools and views to the users. And the advantage of something like Smart on FHIR is that the credentials that you're providing will enable you to sort of aggregate information from what would previously have been multiple point solutions, right? So by connecting to a FHIR endpoint, you can do things like say, get me all of the records associated with my medication history that were encounters of some type, right? And that query would then allow a person who's making the application to be able to construct a view of meds by encounter that was associated with, say, your cardiology condition. That type of functionality, which transcends just a point data source, the kind of functionality that enables you to engage in, at the time of request, information against a back-end system provided by both the provider or a payer, gives you the freedom as an application developer to come up with functions that meet the user's needs with the expectation that the standard will be able to support that. And it's that aspect of FHIR that I think is particularly critical. The fact that FHIR gives you a application interface for querying. It's not just a data feed. It gives you the ability to make operations and requests that leverage the data and take advantage of the fact that the information exists in the provider system or the patient or the payer system, and then access it in a set that is useful for the person who's looking at your application. And it's pretty transformative. It allows you to more or less build what were previously hard to assemble applications by parts, taking advantage of the same solution that was built for somebody else. So not everybody has to have the same solution in mind, but has to have the ability to use that same open standard as provided by Hayes, for example.
So
Duncan or Aneesh, one of the things that I always I wrestle with, or others wrestle with, is the concept of the term app that's used in the Smart on FHIR app. And people either, I like your definition here, Duncan. It seems to me more like a microservice that we're able to deploy and exchange the requisite information that's needed, almost in the back end. Many people hear app and think we're dropping widgets and workflow and other componentry that will only just cloud the experience for the end user. Have you guys run into that problem as well? Just the term app may be overthought of, or I've been leaning a lot towards the concept of more of a microservice. It's almost like a new age B2B. Have you run into those problems as well?
I agree. The terminology and the nomenclature are challenging because there's a lot of existing intellectual property in the market, right? So when people think of apps, they think of their phones, so they envision perhaps an application on their telephone which has a very sort of freighted structure associated with it. And for sure, what we're talking about is something which could be that, but could also very happily not be that. It could be a very lightweight sort of web experience where the information resides permanently in the payer or the provider space, and it's really just taken advantage of in situ.
Yeah, and I think this is where I was trying to go. For this conversation, compliance versus strategic compliance rests on this investment plan. And the reason the term app is used, in a way, there's a regulatory, it's a regulatory definition. The term is application access. That is back to the 21st Century Cures Act. The fundamental right is for consumers to have application access, and then under the 21st Century Cures, to have all parts of the healthcare delivery system foster application access through APIs, standards-based APIs. So that's why the word application is, we think of it in our personal lives, not in the context of healthcare reform. And I appreciate the sensitivity of that being confusing. The reason I wanted to bring this up is, and maybe, frankly, Duncan, you may have to help guide this section of the question. If you are just compliant, not strategically compliant, will you have that microservice or application infrastructure at your fingertips to connect to providers that are similarly required to open up their data using FHIR? Or will only those who opt in to request that strategic componentry see the benefits? My worry here is that we're talking about reuse and leverage, but that's optional. If you just complied, you wouldn't really have those resources. Could you just comment a bit about the average Joe
Sure.
on the street that says, comply, period, what do they get, what don't they get?
Actually, yes, I think this conversation comes up quite a lot in the early phase when we're dealing with payers. The easy comply piece would be, so I have to be able to provide you with a stream of data. My existing systems provide you with a stream of data. Why don't I just format that existing stream and send it to you? And then you would get data, and when you requested it in this point-to-point format that we've always had, this sort of data stream format, and we would be compliant with the requirements. The challenge you're facing when you do it that way is kind of manifold. So on the first part, that's true for today's compliance, right? So if you think about, I need to be able to provide this data stream out now, you'd be following the letter of the law, but you wouldn't be able to subsequently, when the other regulation components become relevant, for example, prior auth or payer-to-payer interactions, you'd end up having to then extend your point solution with another patch on it and then get another patch on it. And so you end up in the circumstance where even in trying to remain compliant, you have to jump through hoops. The moment you have an additional idea, something new you'd like to be able to do for your members or for your clinicians or for anybody else who's able to interact with your information, the moment you have some alternate goal, you have to then try and find either a way to be compliant or you do your own one-off instantly legacy implementation. I think that is the core differential between being simply compliant and strategic. If you're strategic, what you're doing is unlocking the vision and the foresight that the ONC rules sort of wrap. And if you follow that path, you're going to be able to achieve some of the objectives that Hayes had talked about. Hayes, is that aligned with your thinking?
It's perfectly aligned with my thinking. I think some of the payers, definitely because of the CMS side of how we're regulated, don't look often at the ONC side and where the providers have to go with this. They're so very focused on what we have to do now, and so if you don't have that little bit of broader aperture and taking in the ONC side of the equation and just thinking about it as a point-to-point exchange, this is how I'm going to go get my new HEDIS file. We're missing out on the opportunity to unpack that internet of healthcare that you touched on earlier, Duncan. What do you think?
Hayes, yeah, what I'd love to do is take this conversation and share. I put it under the forecasting the future part of the discussion, but let me just highlight it here. It is important to note that the ONC side of the rule, as you point out, creates new functionality by December of 22, so a little over a year and a half from now. And that functionality is called bulk FHIR, and it is explicitly focused on payer-provider data sharing through FHIR. So Hayes, you really teed this up quite nicely because, in my view, compliance versus strategic compliance takes into consideration what is coming so that you're prepared and ready on day one. So just a quick reminder, and Duncan, you're welcome to chime in if I characterize the technology a bit too wonky, but the FHIR is essentially a data model and a transmission method. The data model is intellectual property open source. So if I convert data to a FHIR format, there's no license fee. I don't have to pay a third-party vendor. There's no other friction. I'm able to build an app that reads FHIR data models, contribute to FHIR data models, and there's literally no limitation. It's an open marketplace. FHIR, the transmission method, the version that you all have to meet for compliance, is a single transaction where a consumer unlocks his or her account using their username and password and authorizes a third-party application to make queries within the scope of that single patient record. And that's compliance. Yep. Strategic compliance with respect to the physician engagement, the network piece that you just pointed to, Hayes, that is often on a group of patients. Dr. Smith might have 35 patients that are Blue Cross Illinois members for whom there's contractual agreement to share quality information. What bulk FHIR allows organizations to do is once the data is converted from an EHR proprietary data model into FHIR, and conversely from a proprietary payer data model into FHIR, that there will be an opportunity to cluster all of the information for all 35 patients in the panel that can then enable a kind of a group, what you would call a flat file. Some refer to this as flat FHIR. And that would allow for the exchange. That is not in production in the broadest sense yet, although we'll come back to CMS as a case study, which is in production. That idea of preparing for that capability on the ONC side of the ledger does suggest that if one does not do the strategic compliance, they're missing out on an opportunity. Duncan, can you just maybe clarify for me or correct for me how you are thinking about anticipating the bulk FHIR capability from the ONC side coming to market? And oh, by the way, payers have the same problem on payer-to-payer exchange. So maybe, Duncan, could you just comment a bit about this where we're heading component?
Sure.
We'll come back to strategic versus compliant.
So yeah, before I jump onto that, I just want to reinforce what you said, which is that FHIR extends beyond just a data interchange format. And as you correctly pointed out, it's a data model, but it's also an expansive data model. It's one that over time, payers, providers, and everybody else can contribute to. So it's not, you're not constrained by having a look at where FHIR is today, go, oh, it doesn't do everything I want, so it isn't what I want. The goal of FHIR is to be continuously adapting and improving to meet the needs of the community. And then secondarily, there's another component to that which is really important, which is the notion of operations. So because if you think about the effort it takes to get a bunch of data and then do something with it, the notion of being able to translate it and send it somewhere else and then have somebody else do something against it requires a lot of inefficiency. You have to send the data, you have to package it up, someone has to understand it, interpret it, then do some sort of operation against it. In the current state of the application, you can do things where you say, go and get me the output of this operation. Go and find all of the people who have this condition, who took this medication, who were in this district, and it'll do all that work for you and then send you just the information you care about. Or it'll do things like summarize, count the number of people that did that, give you the summary of it. You have within the scope of this application far more than you've ever seen before in the way we've thought about interoperability. And this is important when we get to the idea of bulk FHIR and everything else, because this comes down to the idea of what I've heard called data unification or information unification. The idea that as you assemble across a bunch of different sources, records that are meaningful to a group of individuals, you can leverage the power of the standardization process to get away from the existing silos that you're in today. That, when you've got something which is coming from a radiology system that has to interoperate with something that came from a lab system that might have come from an EMR, the conversion, the making that available as a bulk transfer in either direction requires you to go down that path of unification. Then it gives you the tooling that you need to be able to do interesting evaluation information across it. I think that's going to be the legacy of what you're asking about, Aneesh. The idea of bulk data transfer, it isn't just that I can move data point to point, and it's definitely coming for that, but it's that I can move data in a unified fashion from across a bunch of infrastructures between participants in ways that are meaningful, that I've structured the type of information I care about, and that the point that the information is gathered can participate in ways that stop them from being point solutions and participatory components of that, what I called previously the Internet of Health. I think that's the driver. When you say what do I see coming? I see that as being the ultimate objective of the bulk FHIR type transactions, is the ability to be very clear about what we're transferring and then why we're transferring and then how to use it.
Well, I want to come to Hayes on this because I think this is perhaps the single most important question on the ultimate cost or burden of making use of clinical data in the healthcare system, this whole $35 billion investment we as a country made to subsidize the adoption and use of these electronic health records. And let me make sure I translate what Duncan said as cleanly as I can. This unification principle is an efficiency principle in my view. Today, Hayes, if you were lucky enough to have a point integration with Dr. Smith and you accepted the data without a unification, maybe it's right out of their lab system, maybe it's right out of their pharmacy system, maybe it's whatever the back end of their EHR system has, and the burden is on you to unify it after you've received it and then make use of it. That Correct. Is door number one. Let's call that the holy moly inefficient doesn't scale door number one. Now Duncan is introducing the idea of door number two. Door number two is that the ONC rule is effectively demanding the unification occur inside Dr. Smith's practice. Dr. Smith will not have a certified EHR unless it has unified all of the what's called the U.S. core data for interoperability, the U.S. CDI data sets. Call it the minimum summary of a patient profile. That unification and that incredibly painful investment at each of these individual data systems, that unification now is going to happen inside their walls, and more importantly, Hayes, without you paying for it. So what bulk FHIR allows you to do, and this is, I think, just to clarify, Duncan, how I've characterized it, if that unification occurs by standard on the other side, then the work on the payer to make use of that EHR data is as easy as requesting the unified data happens to be through a bulk FHIR protocol. But that seems to massively reduce the burden. Maybe Hayes first. Did I mischaracterize that efficiency play? And
it might be like Harry Potter. There may be some sort of door in the middle, you know, like station 9 3/4. There's a stutter step there because the unification is more just from one EHR. The bulk of the work that we attempt to do is, yes, we need to have a better, cleaner, normalized, standardized, deduped record. But part of that deduping is between data types, between data stores, across, not just one clinically integrated system with a really pure EHR, but we got to mix it together with claims and other things. So it does alter the lift what we have to do, but it does not remove it.
Yeah, Duncan, comment on is this a 5% efficiency, a 95% efficiency, somewhere in the middle? Give me the Goldilocks here, Duncan.
So I think ultimately it's going to be a 95% efficiency, right? Because as people move more broadly towards FHIR, and I think this is the other part that's critical. The reason why I call it the Internet of Health is because it is an open standard. In the early days of the internet, there were lots of competing networks and lots of competing technologies. And all of that went by the wayside so that we could have at least a common networking pathway to be able to build websites that people could get to and to be able to find them and stuff like that. Healthcare hasn't gotten there yet. There is no mechanism for us to all communicate together in a nice, clean fashion. And the data we keep is great, but it's locked in vaults that are inaccessible. So the goal that we're trying to get towards is this notion that this open standard is eventually going to be pervasive. And so although the demand is that, that we provide this access to the information, there's an expectation over time that the value of that open standard will, of course, be implemented elsewhere so that it's already in a format that is accessible to payers, for example. So I think in the short run, I agree 100% with what Hayes said, that there's going to be a period where we're trying to make, like we did with the networks, try to make this other network connect to that network using some bridge. But in the long run, I think we get past that and collectively we end up with a better place.
And I think it's this alternative opportunities that once we get past some of this compliance that is really very exciting. I think it does allow for the democratization of data. Whether that's a cleaner package at one provider's office or how I have to weave them all together. But I think it's it's the intent, it's the spirit from CMS and ONC on the democratization of the data, and I truly believe it'll free up, the data acquisition that the carriers look to do. I also think it's going to open the eyes on the provider side on sharing, when we can get to, things that are closer to auth, claims adjudication, record attachments, really asking for the specific information we need to accelerate, other opportunities in the marketplace. I think those accelerants are going to allow us to not make certain investments, which would be some of those other issues that you mentioned earlier, Aneesh, and that we'll probably have a cost avoidance going forward because the democratization, and we all have, so I still think I need to carry a lot of analytics to process everything I'm getting for a while.
Oh, you're telling me you're not going to go to the boss and say, put me down for 50% savings and I can reinvest that in application development? That you're not there yet, Hayes?
I am not there yet.
So this is a great segue to Anirban's question, which I think you just alluded to a bit on prior auth, and I'd like to end a set of these questions on the rule that CMS proposed, ostensibly finalized, but kind of didn't really finalize near the end of the year around a few things. At a minimum, under the brand of reducing physician burden, the notion of naming specific technical methods of data sharing. I think Anirban's questions around payer-to-payer exchange and whether payers need to follow the PCDE FHIR implementation or non-FHIR transactions. I'll happily defer to you, Duncan or Hayes, if you want to take that. But let me lift, before we get into that specific question, the following. CMS gives us a window into the future today. And as we recall, the consumer-facing version of their patient access API, obviously without the clinical data, just the claims, went into production in August of 2018. And CMS made an investment, I think it's back of the envelope, call it, between $5 and $8 million of an investment to stand up their FHIR infrastructure. Now, it took almost a net new build the following year, because the standards didn't really exist, to create a FHIR infrastructure in bulk. So to say, look, we have enabled the consumer use case, but look at all the other places where we could. We have ACO contracts that have access. I have physician networks that want access. And I actually have standalone Part D plans that want access to Part A and B data. CMS introduced 3 bulk FHIR capabilities, but rather than having them be separately funded in a whole new project, in my view, strategically compliant, they anticipated many use cases and have reused the same back-end FHIR infrastructure to lower the marginal cost of each additional use case. As we think about the multi-payer and the vision that CMS put out in the rule, which didn't get finalized for lots of complicated reasons, but the rule that said if you have a Medicaid plan or a healthcare.gov plan, you too must make claims data available to doctors at the point of care. Hayes, could you use this bridge to comment a bit about, either you or Duncan, how the kind of anticipated goals from the physician burden rule might fit your strategy, whether the delay in it being final affects any of your planning or you're plowing ahead? Maybe either of you two could comment a bit about that multi-payer second rule and its limbo land impact on the technical work.
Maybe we can defer to Hayes for the real part. Afterwards, I can talk a bit about theory.
Thank you. We'd like to continue to plow ahead. We got a number of provider partners who we were trying to experiment with just that. Again, it's about having the abilities that our tooling from Smile gives us, and our ability to go out and start working on what's coming next. So, data to point of care from a lot of modalities I've been doing for our plans since probably 2008. I think we've been delivering some form of CCDs back out to the market for ingestion, and it's so I think I beat CMS there. But I do think we're going to just continue to plow ahead with our strategies, and as wherever possible, be multi-payer. We're not going to name all the payers, but we do a lot of work amongst each other. We don't want to. We're not trying to differentiate so much on the provider's glass. We want to get the information where they do business, and we want to do it in a way in which we can get greater lift. So we want to make sure that we're well over 65% of their patient flow. So we try to work with Blue, government, one or two commercials to try to get that type of experience. And what these capabilities are going to allow us to do is not be able to fight over who's got the best widget. And I think it has not stymied us at all, Aneesh. If anything, it's got us scratching our heads like, let's keep the momentum going. But Duncan, I don't know if you want to cover the tech side of it.
Yeah, so I was thinking about the question, right, which is, should we, are we allowed to transfer something other than FHIR for the peer-to-peer interactions and have the technologies sort of, what's our dependency on a technology pathway versus a data exchange pathway? I think obviously, I agree 100% with what Hayes just said, which is we need to continue to provide value and to be able to share information regardless of the technology choices we make. But if we're looking at the future and trying to figure out how should we share information, if we continue down the path that we've been on, where we sort of try and make use of what we have now and treat everything exactly as we have as this point-to-point exchange where I just send you information, it's your problem, we're going to end up with the same problems we have today. We're going to keep doing the same things over and over again, and these inefficiencies will exist. So in the spirit of trying to look forward a little bit, the decision collectively to land on an open data standard, one which nobody has any proprietary ownership of, and one which will make it easy for us to exchange both data from ourselves to others, but also to receive information from them and take advantage of it, seems to be a matter of self-interest and ultimate value. So I think the decision as to whether or not you should switch to FHIR because the demand is that you must switch to FHIR is kind of beside the point. I think the discussion should be, do you see a value in the future of an open approach? Do you see the idea that because I know how to exchange information both directions and I'm able to get value from the character of the transaction, the ability to constrain my request, the ability to expand my request, all the stuff that you get from an open standard like this is really what's going to drive your decision whether or not you're going to try and get to FHIR for your payer-to-payer. Because ultimately, I believe you will. I believe that approach is where the world is going. I think that HL7V2 and other standards have had their day, and this collaborative open strategy is one that's going to move us forward. I don't think you can go beyond that. I don't want to predict tomorrow.
Duncan, it's Hayes. One excellent point. And when I hear you say the thing that resonates for me, and given my tenure in the industry and the rooms I've sat in, I have never seen a more trusting partner on the other side of the providers that we're working with, because I think just of that, the philosophy, the spirit that you mentioned is enabling all this stuff. So the standards are an interesting piece, but I think it is the democratization of the data. It is the land framework. It is the contracts pushing through, and having the FHIR abilities start coming to market where everybody actually understands them fairly well. Those that are playing with them, the level of trust is just so much higher than I would say it was 5 years ago, 10 years ago, 15 years ago. And I think a lot of it's because they understand what they're working with and the rules centered around it and the good lean in. So I think a lot of environmental readiness has got us there. But when I heard you just speak just now, it just really resonated with me, the amount of trust I feel in the room when I'm on the calls with providers, and they just go, oh, okay, we're going to do that now? Okay, great. And we didn't have that before, or the recency.
Yeah,
I agree. Exactly.
We did have a question in the chat around how we might think of the use of FHIR in addressing the No Surprise Billing Act. I certainly have opinions on this. I'm curious, Duncan or Hayes, if you had, again, in the spirit of reuse of the infrastructure, how you might consider it.
Hayes, can I defer that one to you? Because I think this is more in your camp than mine.
Thought it was going to go to you.
Yeah, well, I can if you want. I just didn't want to step on your toes there.
No, you can.
Okay, so the way I see it, of course, is you need to be able to be clear about the service you're going to provide. In order to be able to clear about the service you're going to provide, you have to be able to properly define what that is, and you have to be able to do it in a fashion which can be compared with anybody else. So the way I see the standard playing in this is, of course, giving people a common platform under which to express these objectives, and then giving them the mechanism to manage, maintain, and integrate that with the other characteristics of their service, right? So a standard, a technology doesn't directly inform the decisions that you're making from a business perspective, but given the character of this particular standard, it gives you the ability to make those decisions easily.
Well, maybe I can
confidence that once you make them, yeah.
I'll take moderator.
Aneesh, I appreciate it.
Well, these are policy issues, and I'm passionate about policy issues. So this is another example of compliance versus strategic compliance. And what I mean by that is there exists a price transparency rule independent of the No Surprise Billing Act. The price transparency rule calls on payers to furnish a tool, Duncan, not an API, a tool that can help a consumer find the price and potentially alternatives. It even includes a financial incentive. That is to say, if you gave a gain sharing bonus to consumers to, for lack of a better term, shop and get care at a higher value, lower cost environment, if you were rewarded with like $100 coupon for going to a low cost imaging center, that $100 gain share would qualify within the medical loss ratio. So if a payer was compliant and bought a third-party app to deliver that, gain-sharing portal, for lack of a better term, then you've met the limited, narrow scope of the rule. If you are strategically compliant, you might furnish a FHIR API that would allow not just the tool you bought, but other tools to integrate that kind of information. And one could easily envision a health system, an ER, for example, that is capable of working with you on ensuring that you're going to get a kind of an in-network experience as best they possibly can. And so this issue of information asymmetry, the consumer is going to have a tool. Okay, well, if there was an API instead of a tool, then there could be any number of applications, including at the point of the ER visit, at the moment in time, to say these are the 6 doctors on schedule. Are they all out of network or in network? And so I see that Surprise Billing Act legislation as a terrific example of how a strategically compliant approach to the interoperability rules could facilitate less friction on the other side. And so I don't know if you have a reaction to that or a comment to that, but I was really grateful to see that question from Joel, because it's not obvious we're going to get there until you sort of create the option value with the strategic compliance.
Yeah, so this is a case, Aneesh, where you actually are the key panelist on this. So yeah, I'm glad you were able to answer that. Right, your dual role.
Well, we have another question from Richard Jordan on the Sequoia project and how Nationwide Health Information Exchange might relate to this capability. Again, I have lots of opinions and comments, but Hayes, you've probably been closest to this. Are you thinking about that in any way?
Yeah, I am. Richard, thank you for the question. It's actually, I ask myself that a lot in a lot of rooms. Why do I need all of these people coming to me, pitching to me to buy stuff from them and I've been watching, Chins, Wins, Rios, HIEs, everything for decades now, and now the QHIN and all this stuff. I'm like, what do I really need? I really need I need this type of infrastructure. I would rather have that than all the money will be thrown. I think the Sequoia project, they've done a great job. I'm not down on any of the work in the industry. I think we've come a really long way, and I'm very proud of being part of the family. But I think we will leapfrog a QHIN national information network in the end. Otherwise, you're not really dealing with the Internet of Health. You're dealing with the I don't know. I think we're just doing another play. I'm even more curious by some of the states we're seeing. I saw a release today that California is trying to set up another HIE. I just think if we double down on the types of capabilities and policies that Duncan and Aneesh are talking about, do we really need to have that type of infrastructure? I feel that what Duncan's brought to the market and Aneesh is championing for us is really the verb of an HIE, where the rest of the stuff is the noun of the HIE. I don't need the noun, I need the verb. So we are really continuing to trend towards that verb, and we're trying to do it with FHIR.
I have a comment or two here too, but clearly, Duncan, if you have a word or two on governance, happy to hear you say it, or maybe I'll share a word.
Let's go with your word, Aneesh. It'll be more informative than mine.
Well, I think the nouns and verbs that Hayes just mentioned are at the heart of this problem. It's not a technology issue, and in the pandemic, if you recall, HIEs were effectively limited in sharing access to the records for case reports to public health. And the reason was that the governance of these models limited to treatment applications only. Now, Hayes, I hate to ask you this question, but I presume when you're doing the work you're doing, you're not qualified legally as a treatment application. You're perhaps doing treatment, payment, and operations. And so the constraints of the networks, because of the way HIPAA is governed, has to be on a minimum data necessary framework. Whereas in the application stack for FHIR, you can regulate data use rights at the application layer. So Hayes may be performing a request for information for prior auth. That's governed under a different set of rules. Hayes may be in a value-based care contract where they're sharing responsibility for quality, and data sharing there is more under the care coordination function. You wouldn't want to do two different data networks. You'd want to have two different apps that have different principles. Maybe you could come.
They drive up my cost of ownership and cause a lot of channel conflict and confusion. So I am leery of that. That's why we're trying to align to it's a model where it's more about the application than it is about the standing up of networks.
Well,
I think this is.
Yeah, Hayes.
Go ahead.
Duncan, give us the last word. I mean, I think we're reaching up against the hour. I would love to have you share a bit of reaction from this. Again, context. You're fielding calls from folks who need to comply. We've made a pretty strong case to move towards strategic compliance. And you've gotten a few examples with respect to surprise billing and others that give you examples of what could be used. Bring us home, if you don't mind, Duncan, on where you see us heading.
Sure. So I think what I was going to say is this, for me, is the crux of the idea of the Internet of Health, right? It's this idea that what we're building in the future is not a whole bunch more solutions that solve problems, is we're building an environment, an ecosystem, if you will, in which these problems can be solved. And the way that these problems can be solved on the back of that ecosystem is exactly as you said, being able to take the information availability and then find a new way to compose it that's meaningful for the demand of the day. And so exactly as you suppose, you could have that same set of information available for a decision around cost, and then subsequently available for a decision around whether or not you're able to fund it through that particular pathway, and then subsequently decision around the value of that, whether this is going to be necessary as part of the care plan for this individual. And all of those services, all those capabilities, all wrap up in one strategic bundle. And it doesn't matter whether you're a payer or a provider or some intermediary, all of you get the benefit of that strategy. And so by collectively participating in it, what you're doing is you're meeting the compliance, you're meeting the needs of the day, but you're really building for the future when you're going to come up with new ways and new values. And that's where the previous question about efficiency comes from, right? So today, it might not be the perfect shot to have a FHIR implementation because you can say, well, I already got this other piece of tooling in place, why would I want to change it? But in the long run, you might not need that tool anymore. You might have come up with a complete new mechanism for interacting with the information in a way that you're able to achieve the value that you want without ever having to refer to that tool. And suddenly, $200,000 a year evaporates from your budget because you don't need to be paying somebody for that. You're able to use a more lightweight interface that solves the problem. And as you go down the road, what you can see is that those efficiencies and come back to other budgets you can sort of fill out, right? So how do you find ways to improve care? How do you find ways to be more efficient in the management of care from a payer's perspective? All that value is unlocked by the transition to an open standard and by the adoption of the Internet of Health. Right.
Duncan, it sounds like we need to have a continuation of this conversation. You're hosting a symposium in the near future. Care to say a word and then wrap us up?
Oh yeah, sure. So we've got our user symposium for Smile CDR is in April. Do you have the slide up? Sorry, I was pacing while we were talking because we were in an area that I like to contemplate. So between April 6th and the 8th, we actually have the Smile CDR User Symposium. It's an opportunity where you can hear about how Smile CDR works, how it's being used in a variety of circumstances. Both Aneesh and Hayes will be there to talk about interesting uses of our application in their environments and others too. So just wanted to wrap up with that. And I want to thank everybody for participating. We really appreciate the opportunity to talk to you, and hopefully you got something from us.
Thank you. Thank you, Duncan, Hayes, and Aneesh for sharing your thoughts. And thank you to the audience for participating in today's Fireside Chat. This concludes today's session. Thank you again, and enjoy the rest of your day.